Welcome back to our explainer on airway management. In part one, we laid down the groundwork of assessment. Now we're going to jump right into the hands-on skills you need when things get serious, from the fundamentals of ventilation all the way to the most critical interventions. Okay, so let's dive right back in where we left off. We're starting with probably the most common and one of the most important skills for supporting breathing in an emergency, bag mask ventilation, or BMV for short. Now, this is something you've really got to get. When you do it right, bag mask ventilation can be just as effective as sticking a tube down someone's throat, especially for short periods. It is an absolutely foundational skill that everyone has to master. So you gotta know, not all ventilation bags are the same. Think of the self-inflating one as your workhorse. It's simpler, it'll fill up with air on its own, and you don't need a special gas source to make it work. The flow inflating bag, well, that one's more of a precision instrument. It needs a continuous oxygen flow just to inflate, and it definitely requires a more experienced hand to use it effectively. And that brings us to the technique itself, the EC clamp. And it's really clever how this works, right? It's basically a 2-for-1 move. Your thumb and index finger make a C shape to clamp the mask down and get a good seal. At the same time, your other 3 fingers make an E shape under the jaw to lift it up and open the airway. One hand, 2 crucial jobs. So as you're doing this, you're in this constant feedback loop. You're watching for good signs. Is the chest rising? Are the oxygen numbers getting better? And if you're not seeing that, you have to troubleshoot, like right now. Is the airway still open? Is the mask sealed tight? Is there something blocking the way that I need to suction out? But here's a super important warning. More is not better here. If you squeeze that bag too hard or too fast, you're heading for trouble. You can actually build up so much pressure in the chest that it squeezes the heart and less blood gets out. And you could force air into the stomach, which creates a huge risk of the patient vomiting. Okay, so what happens when bag mask ventilation just isn't cutting it? Well, that's when we have to escalate to the next level, endotracheal intubation. We're talking about placing a breathing tube directly into the trachea to get a completely secure airway. And look, this is a huge deal. You don't just jump to intubation. The reasons are very specific and very serious. You do it when the airway is blocked or is about to be, or when someone is so unresponsive, like a GCS score under 8, that they can't protect their own airway from aspiration. Or sometimes they just need a machine to fully take over the work of breathing. When it comes to intubation, success is like 90% preparation. Before you even think about starting, every single thing on this list has to be out, checked, and ready to grab. You just don't get a do-over to find your gear in the middle of this. And when you're dealing with kids, getting the size right is absolutely critical. These little formulas here, they're your best friend for getting a solid starting point for the tube's internal diameter. And the rule is, you always have the size you calculated, plus one size bigger and one size smaller, ready to go. No exceptions. All right, so the tube's in. Great. But is it in the right place? And let me be clear. There is zero room for error here. Making sure that tube is in the trachea and not down in the esophagus is the single most important step in this whole process. So right away, you're using your eyes and ears. Is the chest moving up and down evenly on both sides? Can you see that little bit of fog in the tube when they breathe out? When you listen with a stethoscope, do you hear good breath sounds everywhere? And, just as important, do you hear nothing over the stomach? But listen, just using your senses isn't enough. You need objective proof. The absolute gold standard is something called capnography, which measures the carbon dioxide they're breathing out. If you're getting CO2 back, you're in the lungs. End of story. That, combined with good oxygen levels, is how you know for sure. Okay, we're going to shift gears down to 2 real break glass in case of emergency procedures. First step is for something called a tension pneumothorax. Basically, air is trapped in the chest, and it's squeezing the life out of the lung and the heart. You have to get that pressure out, and you have to do it now. The fix for this is a needle thoracostomy, or needle decompression. You find your spot, you go in with a big needle, and whoosh! You should actually hear the air escape as that trapped pressure is released. It's important to remember, though, this is a temporary fix. It buys you time until you can get a proper chest tube in place. So, what if the absolute worst happens? You're in that nightmare scenario. You can't intubate, and you can't oxygenate with a bag mask. The patient is not getting air. What is the move? This is where you have to go to the ultimate last resort, creating a surgical airway. We're talking about a needle cricothyrotomy. It's about completely bypassing everything up top and getting oxygen straight into the lungs from the front of the neck. The whole idea here is to get a needle through what's called the cricothyroid membrane. It's this small gap in the cartilage at the front of the neck, and its precise and accessible placement, by the will of Allah, provides this critical window to save a life when no other option is available. So, are there ever times you wouldn't do this? Well, the only absolute deal breaker is if you can actually manage the airway some other, less invasive way. All the other concerns, like bleeding risks or potential injuries, are relative. In a true can't oxygenate situation, the benefit of getting air in almost always outweighs those risks. The procedure itself is pretty direct. You find that membrane, you hold the trachea steady, and you insert the needle at about a 45-degree angle pointing downwards. The second you see those air bubbles pull back into your syringe, you know you're in. That's your confirmation. Then you can hook up oxygen and start ventilating. But there is a major, major risk you have to be aware of, and that's barotrauma, or pressure injury. Think about it. If the airway is totally blocked up top, all that oxygen you're pushing in, it has nowhere to go. It just builds up, and that can cause serious damage to the lungs. All right, so let's boil this all down. What are the big takeaways? First, bag mask ventilation is your bread and butter. Master it. Second, preparation for intubation is everything. Third, confirming tube placement isn't optional. It's mandatory, using every tool you have. And finally, you have to know those emergency procedures cold, just in case. And that really leaves us with one final big question. It's one thing to understand these steps, to see them on a screen, but when the pressure is on, when the alarms are going off and a person can't breathe, how do you train so that all of this becomes pure muscle memory, a true instinct when a life is on the line?